My name is Tariq, and I welcome you to our regular press briefing on global health issues. As always, we have a number of speakers here in the room, but also online that I will progressively introduce. I would like to ask all journalists to clearly indicate their names and outlet they work for, and if they have a question, to click on icon raise hand so you can be put in line. Here in the room, we have, as always, our Director General, Dr. Tedros Adhanom Ghebreyesus. To his left is Dr. Maria Van Kerkhove, Director Interim Epidemic and Pandemic Preparedness and Prevention. Also, on that side of the table is Dr. Abdurrahman Mahmoud, Director at Interim of Alert and Response Coordination. To Dr. Tedros' right is Nabil Tabal, who is Deputy Incident Manager for Occupied Palestinian Territories and Lebanon. And also we have Dr. Michelle Yao, who is Incident Manager for Mpox outbreak. A number of other colleagues are online, and we will introduce them after the opening remarks of Dr. Tedros. With this, I give the floor to our Director General for the opening remarks.
Thank you, Tariq. Good morning, good afternoon, and good evening. As you know, Monday marks 1 year since the horrific attacks by Hamas and other armed groups on Israel. Those attacks began a chain of events that have caused unspeakable suffering to civilians in Israel, Gaza, the West Bank, and now in Lebanon. Since the 7th of October last year, more than 1,500 people have been killed in Israel, almost 42,000 in Gaza, and more than 700 in the West Bank. In addition, more than 10,000 people are missing in Gaza, and 1.9 million people are displaced, while 101 hostages taken from Israel remain in Gaza. In Lebanon, more than 1,600 people have been killed, and more than 1 million displaced, including 350,000 now living in shelters and 160,000 who have crossed the border into the Syrian Arab Republic. 70% of those are Syrians who had sought refuge in Lebanon from the war in their homeland. The government of Syria, the UN and partners are doing their best to respond to this influx, but additional support will be needed. In southern Lebanon, 37 health facilities have been closed, while in Beirut, 3 hospitals have been forced to fully evacuate staff and patients, and another 2 were partially evacuated. Health and humanitarian workers, including W.H.O staff, have done incredible work under very difficult and dangerous conditions with limited supplies. And yet, healthcare continues to come under attack. In Lebanon alone, 28 health workers have been killed in the last 24 hours. Many health workers are not reporting to duty as they fled the areas where they work due to bombardments. This is severely limiting the provision of mass trauma management and continuity of health services. WHO is working with Lebanon's Ministry of Public Health to support effective management of trauma and mass casualty at hospitals. We had planned to deliver a large shipment of trauma and medical supplies tomorrow to Lebanon. Unfortunately, this has not been possible due to the almost complete closure of Beirut's airport. WHO calls on all partners to facilitate flights to deliver much-needed life-saving supplies to Lebanon. The Islamic Republic of Iran's attack on Israel is a dangerous escalation with serious consequences for the region. WHO calls for a de-escalation of the conflict, for healthcare to be protected and not attacked, for access routes to be secured and supplies delivered, and for a ceasefire, a political solution, and peace. The best medicine is peace. Now to Rwanda. where last week the Ministry of Health announced an outbreak of Marburg virus disease. So far, 36 cases have been confirmed, including 11 deaths from 7 of the country's 30 districts. 25 patients are isolated and receiving care. Contact tracing is underway with 300 contacts under follow-up. More than 70% of the confirmed cases are health workers from 2 health facilities in the capital, Kigali, according to the report from the Ministry of Health. This is the first time Marburg virus disease has been reported in Rwanda. The government of Rwanda is coordinating the response with support from W.H.O and partners. W.H.O has sent experts to support the response, including for infection prevention and control, clinical care, logistics, technical expertise, and research. Public health tools, including contact tracing, early detection and care, community engagement, and risk communication, are effective in stopping transmission and saving lives. Treatments and vaccines against Marburg virus disease are in development, and WHO stands ready to facilitate the delivery of these products and to support national research to carry out clinical trials. WHO assesses the risk of this outbreak as very high at the national level, high at the regional level, and low at the global level. Last week, I was at the United Nations General Assembly in New York, where world leaders approved a political declaration on antimicrobial resistance. The declaration includes several targets: to reduce deaths related to AMR by 10% by 2030, to see 80% of countries having access to testing for AMR, to see all health facilities in all countries with water, sanitation, and hygiene services, and to mobilize $100 million to support at least 60% of countries to have funded national action plans. We urge all countries to take immediate action on the commitments they have made and the targets they have set. WHO stands ready to support them to do that. Earlier this week, WHO validated Brazil for the elimination of lymphatic filariasis as a public health problem, and Pakistan for the elimination of trachoma as a public health problem. Lymphatic filariasis is a painful, disfiguring, disabling, and stigmatizing parasitic disease, while trachoma is a bacterial eye disease that's responsible for blindness or visual impairment in about 1.9 million people. In both countries, this achievement is due to unwavering commitment, the target use of medical and public health tools, and the support of many partners. Brazil becomes the 20th country to eliminate lymphatic filariasis, while Pakistan is the 19th to eliminate trachoma. I congratulate both countries. Since 1997, 53 countries have eliminated one or more neglected tropical diseases, including 4 so far this year, with more to come. Again, congratulations to Brazil and Pakistan for this achievement. Finally, this month, October is Breast Cancer Awareness Month. Breast cancer is the most common cancer among women globally. This year, we are highlighting the importance of early detection, timely diagnosis, and comprehensive treatment. In 2021, WHO established a global breast cancer initiative with the goal of reducing breast cancer deaths by 2.5% every year, saving 2.5 million lives over 20 years. Tariq, back to you.
Thank you very much, Dr. Tedros, for these opening remarks. Again, to remind journalists, if you want to ask a question, please click the icon raise hand, and you will be put in the queue. As promised, I will just say who is online from WHO and who will be able to answer some of your questions. Dr. Mike Ryan, Executive Director of WHO Emergency Program, is with us online. Dr. Anaïs Legand, who is a team lead for viral hemorrhagic fevers as well is with us, as well as Dr. Ayadil Saperbekov, team lead for health emergencies at the World Health Organization in the occupied Palestinian territory. Dr. Michel Thieren is WHO Special Representative for Israel, and he's also with us. Dr. Abdel Nasser Abu Bakr is WHO representative in Lebanon. We also have Dr. Ana Maria Henao Restrepo, who is our lead for research and development blueprint for epidemics. And last but not least, Dr. Rogerio Gaspar, Director of Regulation and Pre-Qualification Department. So as you can see, we have lots of people who can answer your question. Dr. Tedros has to leave this press conference because of other commitments, but as you have heard, we have a number of people who will be able to answer any questions. So we will start immediately with the first question. That's Kai Kupferschmidt from Science. Kai, the floor is yours. Please unmute yourself.
Thanks a lot. So I wanted to ask about the Marburg outbreak, and it's two questions really. One, I've been trying to get some basic data on the outbreak, like the death, like the date of death for the index case, and it's been really hard. And I found the press release on it a little bit unusual in the lack of. Sorry, can you hear me? Sorry,
please continue.
Okay, so, sorry. So it's a little bit unusual because there's very few dates, and also I think Tedros just talked about 7 regions in the country. When you look at the map, it looks quite spread out. But from what the Minister of Health of Rwanda just said in the Africa CDC press briefing, that's just contacts that were traced there. So my first question is just, can you give a little bit more detail on on dates or anything we know about whether this is actually one big hospital outbreak in Kigali, or what we know about the outbreak? And then the second question is really, are you at all concerned about the lack of information that you're getting? Is this unusual? Is it what you'd expect? Thank you.
Thank you very much, Kai. We heard very well your question. So we also have Dr. Brian Chiromo, who is our representative in Rwanda that I forgot to introduce. So maybe we can start with Dr. Brian Chiromo from Rwanda, and then we will see if other colleagues here may have something to add. Dr. Brian, can you please get online and answer those 2 questions from Kai?
Thank you very much for those 2 questions. I will respond to them quickly. I think with regards to the first question on the index case, you have asked what the dates are. So based on the information from health authorities, we are aware that the index case died on the 8th of September. So that's the information that we have. We do not have much more shareable information, but at least we do know the date of death of that patient. With regards to the hospitals, yes, indeed, they are the 2 big hospitals, which is the King Faisal Hospital and the University Teaching Hospital of Kigali. So those are the 2 main hospitals where many of the health workers were identified to have been infected. I hope that answers the questions. Over.
Thank you very much, Dr. Brian. And let's go to Dr. Abdi, if you want to add something, Dr. Abdi.
No, thanks. I just wanted to put in context how other Marburg viruses are behaving in the role of super spreading event, particularly nosocomial transmission, the large outbreak we had in Angola and other outbreaks. So we don't have the details. And as DG said, we have sent a large team of epidemiologists that are now well integrated, working very closely with the government. In the coming days, we will have more data analyzed triangulating all sorts of data. But as of now, is the limited available data that we have. It shows that there are two large super spreading events, and that's not unusual for Marburg, previous Marburg outbreak. So rebuilding again, investment in contact tracing, case identification, basic IPC measures, and timely and transparent sharing of information is very critical. And I'm glad to report that the WR and the Honorable Minister have been working very closely, and we really appreciate that transparent and working closely with all member states and also with the partners. So thank you, WR, and thank to the Minister.
Thank you, Dr. Abdi and Dr. Brian Chiromo from Rwanda. We may move to next question. We have Agence France Presse and Christophe Vogt. Christophe, please go ahead.
There you go. Thank you for taking my question. It's about the announcement that was made yesterday evening by Gilead Pharmaceuticals about lenacapavir, making it more available in quite a few countries. Still, there has been some criticism saying it's not going far enough. So I just wanted to know what your take is on that. Thank you.
Christophe, I'm not sure we have someone who can speak particularly on this topic. So let's try to answer that question after the briefing. If you can send us an email, we'll make sure that it's being addressed. So let's move then to Rory O'Neill from Politico. Rory.
Hello, thank you very much. So I have a question on Lebanon and Gaza. So Lebanon's health ministry has been reporting over the past few days the persistent targeting of health workers by Israel. Does W.H.O have evidence of that? And is Lebanon's health system at risk of the kind of collapse we've seen in Gaza? Secondly, final question, is it appropriate for a country such as Israel, which has repeatedly targeted health workers in Gaza and reportedly now Lebanon as well, to serve on the executive board? Thank you very much.
Thank you very much, Rory. So we have two questions. Do we have Dr. Abdi Nasir Abu Bakr, who is our representative in Lebanon, online?
Yes, thank you very much. Well, thank you very much for the question. I think, of course, the healthcare system in Lebanon has been impacted severely for the current crisis. And as you know, the Lebanon has been, struggling for previous crises, whether it's a political, economic crisis, Beirut blast, COVID pandemic, and the fragility of the health system, it's evident. And the current crisis actually, has been impacted, unprecedentedly. And I think currently also the hospitals are functioning, majority of them are managing the mass casualty management. But the question is how long they can function if the escalation continue. I think currently many hospitals are already saturating, and we are, and some of the health facilities are closed. Some health facilities, some hospitals have been already evacuated. I think what I can say for now is the capacity to do mass casualty management exists. But it's just a matter of time until the system actually reaches to its limit. And we're really just advocating, of course, one, for the protection of health facilities and healthcare staff. But at the same time, as the DG have raised, actually, we are advocating for peace and stability. So at least, we can better serve the people who are affected by the conflict, because we have almost 1 million people that has been displaced for current crisis. Regarding the impact on, the attack of health facilities and healthcare, I think so far, what has been WHO documented is 35 attacks on healthcare. 73 healthcare workers were killed, including 28, as the DG have said that has been killed for yesterday, and 67 health workers that have been injured. And as a WHO, we continue to advocate the protection and respect of healthcare, both the facilities and healthcare for all sides. Thank you.
Thank you very much, Dr. Abdi Nasir, for your intervention from Lebanon. And maybe on the question of membership to executive board, do we have our Principal Legal Officer Steve Solomon online?
Yes, thank you very much. And can you hear me well?
We can hear you, please.
I think the question was concerning Israel's membership on the executive board and the actions that might be attributed to it. I think it's important to understand that the WHO executive board, the 34 member states on the executive board, are determined by the member states themselves. So 194 member states of the organization democratically vote on the membership of the executive board. Often those votes are done by consensus. Often those votes are a product of work at the regional level, which is then brought to the Health Assembly. This is all to say that the determination of which countries sit on the executive board in a rotating fashion, another important point to recall, that determination is made by the member states themselves. So I hope that clarifies the nature of the executive board, and thank you very much.
Thank you very much, Mr. Solomon, for clarifying this. Again, reminding journalists, if you want to ask a question, please click the icon, raise hand. We have Belissa Godinho from W Magazine, Portugal. Belissa?
Hi.
Yes, we can hear you.
Okay, thank you very much. My question is, what makes coronavirus respiratory syndrome different from previous virus spread around the world? Is it the problem local? Was it detected only in the Kingdom of Saudi Arabia? Can you clarify the matter? Thank you.
Thank you very much, Belissa. I think you referred to MERS, Middle Eastern Respiratory Syndrome. Dr. Van Kerkhove may take this one.
Yeah, thanks very much. So MERS coronavirus is one of the coronaviruses that have pandemic potential. It's only been epidemic so far. There have been about 2,600 cases that have been reported globally. Most of the cases have been reported from the Kingdom of Saudi Arabia. It's a zoonotic pathogen where dromedary camels, people with contact with infected dromedary camels can get infected, and we do see some human-to-human transmission, mainly in outbreaks in healthcare facilities. There has been a recent case that has been reported, and we just published a disease outbreak news of this individual. This is one of those viruses that has been on our radar since 2012, where the first human cases were detected from Jordan and from Saudi Arabia. We know that this virus has been circulating in dromedary camels probably since about the 80s or so. That's the most up-to-date data that we have from dromedary camels from serosurveys. So it's really critical that countries have good surveillance for MERS coronavirus. In addition to SARS-CoV-2, it's another coronavirus, and that we're working with countries mainly across the Middle East where these dromedary camels are. But it's really important that we have strong respiratory disease surveillance around the world. And again, during COVID, PCR-based systems have been significantly strengthened, and this is something that is of benefit for any of these types of pathogens, many of the types of pathogens that we're talking about today.
Thank you very much, Dr. Van Kerkhove, for this. Hope this answers the question. And now we will go to John Zagacostas, who writes for Lancet. John?
Yes, good afternoon. It's a follow-up question to my colleagues. I was wondering if possibly if the WHO rep in Lebanon can give us more details on the 28 health workers that Dr. Tedros mentioned were killed in the last 24 hours. Were they, how were they killed? If you have the details, I know you have your tracking service that independently verifies the various attacks on healthcare. That would be helpful, and perhaps if Dr. Ryan can chip in, thanks as well.
Thank you, John. So you already gave us orders who will speak. So let's start with Dr. Abdel Nasser, and then Dr. Ryan may wants to add something.
Yes, thank you very much. I think, according to the information that we have through the Minister of Health, most of those healthcare workers that's been killed for the last 24 hours, most of them were, actually all of them were on duty. Some of them were in the ambulances, some of them were in the health facilities. And the Minister of Health confirmed that, all those killed and those who were injured for the last 24 hours, even 48 hours, they were on duty trying to help, civilians who have been wounded for the conflict into that. So that's exactly what information that we have, and we rely on the report from the Minister of Health, and we have our strong surveillance system to gather that information. But I think more of the detail is probably I will leave with my client to elaborate more on this issue, because it's not something that has happened right now in Lebanon, but I think it's happening across many of the conflict-affected area where the health care, both facilities and healthcare workers, is being targeted indiscriminately, and that's actually impacting the service provision of the vulnerable people. Over.
Thank you very much. I think this answered the question. Unless Dr. Ryan wants to add something, we may want to go to the next question. Let's go to Albert Otti from DPA. Albert, please unmute yourself.
Hello, Albert Otti, DPA. I have one more follow-up question also on the killed healthcare workers in Lebanon. The 73 that have been killed so far in total, since when have those been killed? What is the starting point of that count?
Let's start maybe again with Dr. Abdinasir Abubakar.
Yes, the starting point actually is the 8th of October. Since the conflict started, the Gaza is built over conflict, at the border, between Israel and Lebanon side. I think the counting started from that time until as of today, actually, this morning.
Thank you very much. Maybe we have Nabil Tabal, who may add something.
Yes, just to add, so indeed, as WR said, so we as WHO, we're mandated by the member states to set up the monitoring system for attacks on healthcare. And this has been indeed set up in Lebanon with the start of the hostilities in 8th of October last year. So all figures that we're providing are cumulative since that point. And this also, it's independent monitoring and reporting that goes also through a verification process. Over.
Thank you very much. And really, we should not forget that behind all these numbers are health workers who are trying to save lives, who are putting their lives at risk, and they should never be a target, as we always say. We don't have any other questions as much as I can see. So we will close. Or maybe one more. Let's just hear. Who do we have? So we have someone from Lancet. I didn't get the name my colleague just mentioned, but please, I think it's Paul. Paul, please unmute yourself and go ahead. You will have the last question.
Yes, thank you very much. I want to take the conversation to the Marburg response outbreak in Rwanda. And when Mpox outbreak began, we had the emergency use listing for some vaccine candidates. I would like to know whether we have an update regarding something similar for Marburg response in Rwanda. Thank you.
Thank you very much. So we may turn to Dr. Rogério Gaspar or Dr. Ana Maria Henao Restrepo to tell us where we are with the emergency use listing for Marburg. So Dr. Gaspar, would you like to start?
For Marburg, not at the moment. We are talking about Marburg or Mpox?
We talk about Marburg. So maybe then, then let's go to Ana Maria.
Yeah, good afternoon. Just to clarify that we have candidate vaccines and candidate therapeutics, but they don't have yet the clinical efficacy data or immunogenicity that will allow our colleagues in the regulatory team to proceed with the emergency use listing. As Dr. Tedros says, WHO has been working with a consortium of over 180 researchers and developers from all around the world. And we hope that we all continue to work collectively and together to support the government of Rwanda to seek the opportunity to evaluate these candidate vaccines and therapeutics using a state-of-the-art randomized trials as recommended by WHO. So yes, it's important, but we don't have the evidence for the colleagues to move forward with emergency use listings. Thank you.
Thank you very much. And I understand that part of the question was on mpox. So let's go back to Dr. Gaspar to address issues on mpox.
Okay, so on mpox, thank you so much. On mpox, on the vaccines, as you know, we had the pre-qualification of the Bavarian Nordic vaccine. We are now working on the final review for the extension for 12 to 17, following the approval by the European Medicines Agency. We are planning to issue a final declaration, hopefully of approval, either tomorrow or on Monday. So it's eminently approval with extension for 12 to 17, not yet concluded. A number of details need to be concluded by the team during the day of today, tomorrow, and we hope to close it by tomorrow. On LC16, we are on the final rounds of questions. As you might imagine, there's a number of issues with the vaccine that was developed a long time ago to suit adequate criteria in terms of the programmatic suitability. These issues have been dealt. I think we are now on the third round of questions on some of the technical issues, very close to conclude. I don't want to share numbers, but it's only a few questions still pending that we hope to solve during next week. Once those questions are solved, we will convene the technical advisory group. In principle, we have a date now scheduled for October 21st. So that's our first priority in terms of approval of the UL for the LC16. ACAM 2000, we have finalized the legal arrangements that will allow the company to submit data. And once the data is submitted, we'll take first the decision if the data is sufficient for UL or PQ. And during the approval, of course, we will have to consider the specific situation of ICAM 2000, some target populations, the conditions for deployment in the specific setting. So I cannot anticipate either a positive or negative opinion, and I cannot anticipate right now if it will be EUL or PQ. It will be driven by data. As you all know, there's a recommendation from SAGE on the use of this vaccine on a specific setting, and the full marketing authorization by the US FDA, for example, implies control of every single person that is administered the vaccine to understand if they are immunocompromised or not, and specifically if they are seropositive for HIV. So there's a number of barriers there for the use of that vaccine in the specific setting. We are long from taking a decision. On diagnostics, I can announce that is imminent. I think we are preparing to issue today a press release on the emergency use listing of the first diagnostic for mpox, which will be Abbott. We are already on the second company that submitted in the evaluation. Both of them are abridged EUL procedures, and we are starting the evaluation for a third diagnostic, and this one will be a full EUL also. So during the next 2 weeks, I think that we will have more news on these two. Time of assessment for the Abbott diagnostic, for those of you that track these things, was 10 days. So this is what I can report for the moment. Thank you.
Thank you very much, Dr. Gaspar and Dr. Restrepo, for update on where we are with tools for mpox and Marburg. We have more questions coming. Let's go to Jamie Keaton from Associated Press. Jamie.
Thank you, Tarek. Can you hear me?
Yes.
Great, thank you. My question is also for Dr. Gaspar. You said from 12 to 17 on the listing for the mpox. I assume you mean 12 to 17 years old. And could you please specify what you know about what percentage of children in DRC, because we know that children are the most affected, fall into that age category? Thanks.
Thank you very much. So maybe Dr. Gaspar, but we also have Dr. Michelle Yao, who is incident manager for mpox. Dr. Gaspar, would you like to start?
On epidemiology, I have to defer to my colleagues.
Okay, so Dr. Yao.
Tariq, if you want, I can talk.
Please go ahead.
Yes, Dr. Ana Maria, please go ahead.
Yes, to say that it is important to consider that the epidemiology changes according to the area. And we have two kinds of virus circulating in the DRC and in Africa in general now. One is the clade 1A that is linked to the endemic disease and mostly affects children. It comes from zoonotic transmission, from spillover events from communities, and the evidence suggests that there are multiple zoonotic events occurring now, and again affects mostly children, and now also some adults when some human-to-human transmission is established, but these networks of human-to-human transmission are small. In these communities, the percentage of children in the population could be up to 40%. So, and if you go to 18 years of age, it could be 60% of the population who is below 18 years of age. And then we have the second clade 1B, that is more circulating in the kibbutz and spreading to other countries, as you have heard, in Burundi, Rwanda, Kenya, and Uganda. And this clade has different patterns of transmission. So there have been some of the networks of transmission in which the virus enters in community mostly through adults. But then once it's established in the communities, we have seen in the different areas that it affects children and adolescents and adults. Perhaps transmission from adults to children or from children to adults. There is work towards that. And regarding the population, it's the same. The majority of the population, about 50 to 60%, depending on the area, could be below the age of 18 and about 40% below the age of 12. Thank you.
Thank you very much, Dr. Ana Maria. Dr. Mike Ryan would like to add something. Dr. Ryan?
Yes, and maybe just supplement on Maria, the SAGE have made recommendations potentially for the use of those vaccines in younger children. So again, off-label use is possible, but that would have to be approved by national authorities. But what Rogerio is talking about is a specific EUL as in a licensing process. So there are opportunities to be able to vaccinate children. I think it's very important that those opportunities are taken and that the necessary processes are put in place to make that happen. I fully agree with Ana Maria's analysis of the epidemiologic situation. We're not dealing, and Tedros has said this previously, we're not dealing with one event, we're dealing with many events. And the zoonotic component in clade 1A is very significant, and we need to gain a much better, quicker understanding of what's actually dynamically happening at the animal-human interface in that situation. Again, with Marburg and previous questions, there's a strong focus on vaccines as major countermeasures. I would argue and thank Rogerio and his team for the work they're doing on diagnostics for both, particularly in the mpox situation. Vaccination by itself, without the targeting of surveillance, is going to not have the impact that we want it to have. The primary intervention here is good surveillance, engage communities, helping communities to prevent transmission from person to person. And Maria has outlined how that dynamic is happening, or from animals to humans. This is the classic public health measures. Vaccines won't solve failures of surveillance. Vaccines won't solve failures in public health measures. Vaccines will supplement and make those interventions more powerful. We need to be exceptionally careful here that this is not a vaccines issue. This is adding vaccine in a targeted way to an already functioning program of case detection, contact tracing, community engagement, empowering and investing in communities to prevent transmission from person to person, whatever the transmission is occurring, like whatever intimate contact is driving that. Vaccine introduced into that kind of program will have a doubling and tripling effect on effectiveness. In the case of Marburg, for example, vaccines have never been a solution in previous Marburg outbreaks. The Marburg has been, as Abdi has alluded to, essentially nosocomial events in the past. There is community transmission, but what we've seen is Marburg virus exploiting situations where there are failures of infection prevention and control, very often in sophisticated hospitals where there are multiple interventions in patients. So therefore, in the laudable act of trying to provide assistance, healthcare itself can become embroiled in the transmission chain. We saw that in Hong Kong during SARS-1. We saw that in Canada. We've seen that in COVID and other situations. This is not unusual. But what it does mean is that the major amplification events in Marburg are not occurring in the community, they're occurring within healthcare facilities. And that's why it's exceptionally important that the surveillance systems and the infection prevention and control systems within healthcare facilities in Rwanda are being beefed up, and we're very grateful for that. That's the major intervention. With regard to vaccines, there are candidate vaccines and have been candidate vaccines much further up the chain, up the research chain. And Anna-Marie and her team and many colleagues in many institutions, including principal investigators in all the at-risk countries for Marburg, for Sudan virus disease and other diseases, have been working on master protocols for over a year, 2 years now, looking at establishing a mechanism where we can deploy investigational use vaccines in properly controlled research conditions that will allow us both to deploy those vaccines for the assistance of people, but also, crucially, to gather the necessary clinical data that will allow those vaccines to advance in terms of their licensing. So we can avoid emergency use licensing in the future, that we can get licensed products available at an appropriate cost to all countries at risk of these rare but devastating diseases. And I would thank Anna Maria for the work that she has led with the R&D Blueprint for Epidemics and all of the partners out there. It's exceptionally important that we do collect that data. But again, vaccines are not required to stop Marburg. What's required is a strong public health program, which we have every confidence the government of Rwanda will put in place, especially around infection prevention and control. And then we need to deploy vaccines in a way that we can collect the necessary information that will allow us to further advance their use in future epidemics. Over.
Thank you very much, Dr. Ryan. And before we close this press briefing, let's just take the follow-up question from John Zagakostas. John.
Yes, thank you, Tariq. It actually concerns what Dr. Tedros mentioned about the emergency supplies that you were trying to get into Lebanon and they had to be postponed because of security measures concerning the airport, whatever. Are you looking at alternative routes to get these emergency supplies in, either by sea or by land? Thank you.
Thank you very much. Dr. Abdel-Nasir, would you like to start?
Yes, thank you very much. I think, first we are trying to address some of those shortcomings because the airport officially is not closed, but many of the international airlines have suspended the flights to Beirut. The only airline that's flying is the Middle East. And unfortunately, the Middle East doesn't have the cargo in planes to transport. And other, private charter flights, actually the challenge is the insurance as well as the security. So WHO is currently, of course, exploring all options, whether it's, negotiating with the friendly countries to facilitate, the transportation of those supplies from Dubai to Beirut, but also other options, whether it's through sea, but also through, by road, via, Jordan and Syria and other options. I think, we want to exhaust, the air option. If the air option transportation is not, viable, then I think we need to, resource for other options into that. But as of now, I think there are some, that's why the DG has appealed other countries to assist for air, transportation to facilitate those supplies, especially the life-saving supplies that we really need to maintain, the mass casualty management.
Thank you very much, Dr. Abdel-Nasir, and thanks to all of our experts who were online with us today and here in the room. Thanks also to all journalists who were following us and others as well on our social media platforms. With this, we will wish you a very nice end of the day and see you next time for our next press briefing.